This is final of the final year, na? So you have been taught many subjects about traumatology, upper limb trauma and all. Yes? Okay. So I'll be talking about the ankle fractures. These are very common injuries. And to understand ankle fractures, it is very important first to understand the ankle anatomy. Because if we do not understand ankle anatomy, we will not be able to understand the ankle fractures, the pattern of fractures. And if we are not able to understand the pattern of fractures, we would not know how to treat these fractures surgically and how to fix them and whether they require a surgery or they do not require surgery. So how the ankle joint is formed? It is formed by three bones: distal end of tibia, distal end of fibula, and the talus. So the widened lower end of the tibia, this is called tibial plafond, and together with the tibial plafond, together with the medial malleolus and the lateral malleolus, which is a part of the fibula, distal part of the fibula, it makes ankle mortise. It makes a socket into which the dome of the talus sits. So the dome of the talus and the tibial plafond and the lateral malleolus together, they make the ankle joint. So this ankle joint is a kind of a hinge joint. And what is a hinge joint? The hinge joint is one which has movements only in one direction, like flexion, extension, or abduction and extension. So in case of the ankle, it is flexion extension. Once the foot is taken upwards, which is called extension, actually we call it dorsiflexion to differentiate it from the plantar flexion, where the foot goes plantarward. So these three bones, the distal tibia, the fibula, and the talus, which is making the ankle joint, needs stabilization, and this stabilization is provided by the ankle joint ligaments. These ligaments are fibrous, tough structures which prevent the bones from getting fractured or dislocated when the ankle joint is subject to trauma. So it is important to remember that there are three sets of ligaments around the ankle, the integrity of which is very important, and we must understand the anatomy of these ligaments, because depending upon the pattern of the trauma that the ankle is subjected to, a particular ligament can get ruptured or strained. So what are these three groups of ligaments? On the medial side, there is deltoid ligament. On the lateral side, there is lateral ligament of the ankle, which joins the fibula, and distally the talus and the calcaneum. And thirdly, it is the tibiofibular ligament or interosseous ligament, which binds together the distal end of the tibia and the fibula. So we need to understand these three ligaments very well and their components. On the medial side, as you know, there is this deltoid ligament. So this deltoid ligament consists of two parts. One is superficial and the other is a deep. The superficial deltoid ligament consists of four components. The superficial ankle ligament actually crosses the talus and joins to the bones which are beyond the ankle joint. So the most anterior part is the superficial talotibial ligament. Next to is tibio spring ligament, which arises from the medial malleolus and goes to join the spring ligament. Settle down quickly. So the third component is the calcaneofibular ligament, and lastly the tibio-talar ligament, superficial. So this four strands make the superficial component. The deep component, which is the deep tibio-talar ligament, has got two components again, anterior and posterior. So in all, deltoid ligament, superficial and deep component, lies on the medial sides, arises from the medial malleus and joins to the various bones. Like deltoid ligament is on the medial side, there is a lateral ligament on the lateral side, which has got attachment at the lateral malleus. Now this ligament also has got three components. Anteriorly, it is the anterior tibiofibular ligament. Actually, it should be anterior talofibular ligament, which is this. So we are talking of the lateral ligament. First component is anterior talofibular ligament, which joins the lateral malleus anteriorly to the talar bone. The second component is the calcaneofibular ligament, and posteriorly is the posterior talofibular ligament. So there is deltoid ligament, there is lateral ligament, and thirdly there is the tibiofibular ligament, also called as the syndesmotic ligaments. This ligament joins the distal tibia to the fibula. So it also has got four components. Anteriorly, it is the anterior inferior because it is on the distal part, tibiofibular ligament, which is this ligament. Posteriorly, it is the on the back side, posterior inferior tibiofibular ligament. In between anterior side and the posterior side, there is transverse tibiofibular ligament, and just superior to this inferior tibiofibular syndesmosis, there is interosseous ligament, which joins the tibia and the fibula together. So just to recapitulate once again, ankle has got three important ligaments: medial ligament, which is the deltoid, lateral ligament, and then the syndesmotic ligaments. So any of these ligament structures can also be damaged along with the ankle fractures, and we must assess which ligaments are injured and what repair, whether it needs to be repaired or not. So just to go into the details, because syndesmosis is a very important joint which is joined together by the ligaments. So here is AITFL, anterior inferior tibiofibular ligament. Just like this, posteriorly there is PITFL, which is posterior inferior tibial ligament. In between these two is transverse talofibular ligament, and above is the interosseous ligament. So if you see at here at this section, this is the tibia, fibula, interosseous ligament. Again, at the level of the ankle joint, you have this section. This is the anterior side, that is the posterior side. So this is AITFL, this is PITFL, this is transverse tibiofibular ligament or interosseous ligament. So that was about the ligaments. So biomechanics, there is dorsiflexion of around 30 degrees, which is actually the extension, but we call it dorsiflexion to make things very clear. Plantar flexion is around 45 degrees. So before we move on to bony injuries and the ankle fractures, we must remember these ligament injuries are very common in the ankles. Every now and then we are playing, we twist our ankle and we say this ligament is injured. So the most commonly injured ligament is the ATFL, anterior talofibular ligament, which is a part of the lateral ligament of the ankle joint. The next common is the calcaneofibular ligament, which is again the middle part of the lateral ligament. Okay. And how do we grade these ligament injuries? If there is just the stretching of the ligament, it is grade 1. If a few fibers get torn, it is grade 2 or a partial tear. And in grade 3, there is complete tear of the ligament. So as long as grade 1 or grade 2 sprain is there, we treat these ligament injuries conservatively, either with a plaster cast or maybe a crepe bandage support for some time. But if there is a complete tear, there is going to be instability at the ankle joints. So this may require a ligament reconstruction, a ligament repair, or reinforcement surgeries. So coming to the ankle fractures proper, these are the most common injuries, and management of these fractures would depend upon identification of the extent of the bony injury. Now this identification of the bony injury is not very obvious on the x-rays. You have to understand the fine anatomy of the bone, the distal tibia, fibula and the talus, and then think whether it is a minor fracture which is obvious on the x-ray, or it could be some very subtle fractures which may be revealed on CT scans, or whether it's a ligament avulsion. So, and the key to the successful outcome of these ankle injuries is anatomic restoration of the bony fractures, fixation. What is the mechanism of the injury? The pattern of ankle fracture would depend upon many factors. First, in which the position the foot is, whether it is dorsiflex, whether it is plantar flex, whether it is inverted or everted. A combination of this movement is called supination and pronation. So, supination movement is one where your ankle has got some inversion and some plantar flexion, while pronation movement is one where it is slightly everted and dorsiflex. So that depending upon whether the foot is supination or pronation, and depending upon the force of the injury that is subjected onto the ankle, that will determine what part of the ankle is fractured. It will also depend on the patient's age, because in young children where the bone is growing, we have the epiphyseal injuries. So epiphysis may be damaged, and if the severity of the grade of the injury is too much, the epiphysis is damaged, no matter how anatomically you restore the bones, the epiphyseal damage will lead to some growth abnormality in the adulthood, maybe angular or rotatory deformities. The management, have we closed the door, Nihal? So there are some students. Ask them to either wait outside or maybe they can skip the class. There's no. So it also depends on the bone quality. In old age osteoporosis, the ankle gets easily fractured, and in those patients, it's not easy to do plate or screws, because even the plate fixation or the screw fixation will also fail. So there we have to use some different strategy for the management. So the mechanism of injury has got a great bearing on what type of fracture you get and how do we manage. So once a patient comes, how do we clinically evaluate? The patient may have variable presentation, may have only minor limp, in case whether, like for example, he may have a sprain of the lateral ligament of the ankle joint, which can be treated conservatively, or a patient may present to you with a lot of swelling and deformity at the ankle joint, and you suspect a major ankle injury. Neurovascular examination is of utmost importance, because these neurovascular injuries, if they are associated with ankle injuries, take the precedence over the management of the fractures. Vascular, because this may put the entire foot at risk of survival, and neural injuries, if they are not properly treated as an emergency case, may not recover. So neurovascular examination, exclusion of neurovascular injuries is of paramount importance. Then you must do a clinical examination, palpate the entire length of the fibula, the medial malleolus, the distal tibia, where is the tenderness, and also the soft tissue attachments of the ligaments. Leave it till that. So I have already told you how the deltoid ligament gets attachment, whether those points are tender or not tender, where the lateral ligament is attached, whether that point is tender or not. So next, having done a clinical assessment, we come to the radiological examination, and this is the most important part which I would be explaining to you, and you should try to understand. I hope the anatomy is clear. We know the medial deltoid ligament, we know the lateral ligament, we know the syndesmotic ligaments, the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, and the transverse tibiofibular ligament, or the interosseous ligaments. Now these ligament structures are very important. In our radiological assessment also we cannot see these ligaments, but we will try to assess which ligament is injured, and on this injury pattern will depend upon management. So what are the basic x-rays that we ask the patient to do is the AP view of the ankle, the lateral view of the ankle. Now that is, this principle applies to any bone fracture. We have to take x-rays in two orthogonal planes, 90 degrees to each other, AP and lateral. But in case of ankle joint, because the tibia and the fibula, they have some overlapping, we take mortise view. What is mortise view? It is just 20-degree internal rotation of the foot, and then we take an AP view. So this removes the overlap of the tibia and the fibula, and we get a clear picture of the relationship between the distal end of the tibia and the fibula. So on the AP view, it is important to see that the fibula is longer than the media. Your lateral malleolus tip is distal to the medial malleolar tip. Always see, because in all these fractures, fibula often gets shortened. And when fibula gets shortened, it puts an indirect strain to the other ligaments. Like if this gets shortened, there may be some displacement of the talus along with that fragment, and this can lead to a deltoid ligament injury on the medial side. So important note is that the fibular malleolus is longer than the tibial malleolus or the medial malleolus. This anatomic feature, important for maintaining ankle stability, is crucial for reconstruction of the fractured ankle joint. Whenever we are doing surgery, we must restore this anatomy. Even minimal displacement or shortening of the lateral malleolus, this allows lateral talar shift, because along with these lateral ligaments, it carries the talus also, and this will put indirect strain on the medial structures. Then what do you see on the AP view? Besides the tip of the lateral malleolus and the medial malleolus, you see tibiofibular overlap. Now this tibia and this fibula, here there is an overlap. So you must ensure that this overlap is minimum 6 mm. It should not be less than 6 mm. If it is more than 6 mm, it is a normal thing. Tibiofibular clear space between the lateral side of the tibia and the medial aspect of the fibula, there is a clear space. This is not visible in AP view, but we'll see the mortise view where it should be clear. And this, why is there clear space? There is this part of the tibia is called incisura fibularis, where the fibula fits into it. So this is depicted by a line drawn from the proximally from the lateral side of the tibia and drawn straight down from here to here. So this part of the tibia is incisura fibularis, into which the fibula sits into it. So this clear space should be less than 6 mm. If in AP view or in the mortise view it exceeds, then it means there is ligamentous injury. Lastly, the talar tilt. Usually the talar dome, this line and the tibial plafond line are parallel. If they are tilting, and if this tilt is more than 2 degrees, that means there is a significant ankle injury. So this is tibiofibular overlap, should be more than 6 mm. This is tibiofibular clear space, should be less than 6 mm. And this is the talar tilt. The lines should be parallel, but if they are not parallel, then that means they are making an angle, and this should be less than 2 degrees. Now what do we see in the lateral view? In the lateral view, we see this is the anterior part, this is the posterior part, that is the fibula, this is the tibia, that is the talar dome, and here if this part is fractured, this is a posterior malleolus. So medial malleolus, lateral malleolus, and now we have a posterior malleolus fragment also. This can be fractured. And we should also see whether this talar dome is centered under the tibia or not. If it is not, then the ankle joint is subluxated, and we must restore the anatomy. There may be associated injuries to the talar bone. That means there may be fracture of the head or neck of the bone, or there may be fracture of the calcaneum as well. Now, what is view? This, as I've already told you, this is a 20-degree internal rotation AP view of the ankle, which is called a mortise view, and it is useful in evaluation of the articular surface between talar dome and mortise. So this is the mortise X-ray, and it is very important to assess your medial clear space. Which ligament is here? So we have three ligaments. I'll keep on repeating so that you understand. So this is the medial ligament, deltoid ligament, which has got two components, superficial and deep. This can be injured. If it gets injured, your ankle can get subluxated. On the lateral side, there is the lateral ligament of the ankle, anterior talofibular ligament, calcaneofibular ligament, and the posterior talofibular ligament. This stabilizes the ankle joint from the lateral side. And lastly, there are syndesmotic ligaments, which is anterior tibiofibular ligament, posterior tibiofibular ligament, and transverse tibiofibular ligament, and then there is interosseous ligament. So interosseous ligament are maintaining the integrity, or they are stabilizing the distal tibia and fibula. The deltoid ligament is giving a stabilization force on the medial side, and lateral ligament on the lateral side. So if the medial clear space is less than 4 mm, it is normal. But if it is more than 4 mm, this suggests the talar body shift. Now, how can talar body shift? It can only shift if there is deltoid tendon rupture. Okay. Then this is a mortise view of the ankle. So look at the clear space. It should be less than 6 mm. Now, what do you look at the in the mortise view is the tibio-talar congruity. So there is one Shenton's line. We have learned about the Shenton's line in the hip joint. I hope you remember pelvis X-rays. We have a Shenton's line there which tells us about whether there is fracture neck, femur, or there is dislocation of the hip or not. Similarly, this Shenton line is drawn by drawing a line along the articular surface of the tibia plafond, which goes on to the lateral malleolus. So this makes a smooth curve. And you have to evaluate whether this smooth curve is broken or not. If it is broken, that means there is talar shift. So this is the smooth line. It is maintained here. Then besides AP, lateral and mortise views, sometimes we need to take stress views, because you may not see a good deltoid ligament injury you cannot see on the X-rays, but indirectly you have to assess. Despite the injury, there may be a normal medial joint space between the medial malleolus and the talus. So sometimes we suspect that there is an injury, but in the X-ray it doesn't show up. So we have to take the stress views. How these stress views are taken? Make the patient lie on the bed, lateral side, foot turned outside, so that the foot is allowed to fall by gravity. If there is deltoid ligament injury, the talus and the foot will fall down, and if you take an X-ray in this view, you will see that the joint space, the medial joint space, is more than 4 mm. Another method is you evert the foot. Again, you are forcibly trying to distance talus from the medial malleolus. So with this stress view, you may find an X-ray in which the space gets increased. If so, sometimes despite all these X-rays, you still see, no, I am not able to make a full diagnosis on the what bone is fractured, what ligament is injured. There must be some hairline, some minor fracture. So CT is the next investigation where you can diagnose small fractures which are not visible on the X-rays. And MRI may also be required if you have any neurovascular injury doubt, or you have any other ligament or tendon injury doubt. So MRI can be done in those cases. Now, all these injuries, once we diagnose on the X-rays, we have to find out whether it is stable or unstable. Why is it important? Because a stable injury is one in which if the fracture is not displaced, if you treat him in plaster, or if you do not treat him, just put the patient to bed rest, it will heal. But if this injury pattern happens to be unstable, then what will happen? Even if you have put him in plaster, or if you have not put in plaster, there are certain forces which are applied on the ankle joint. Right now, this fracture may look undisplaced, but later on, with the normal forces, normal mechanical stresses that are brought on to the ankle joint, it can get displaced. So these positional fractures are called unstable. How to diagnose whether the fracture is stable or unstable? So there is a ring concept. As I told you, this is distal tibia, tibia profonde. As we go on to the medial side, that is the medial malleus. Further down, there is a soft tissue which is deltoid ligament. Then we go on to the calcaneum. Then there is lateral ligament of the ankle joint. Then there is lateral malleus itself. And there is this syndesmotic ligament. So all these structures together make a ring. If it is broken at one place, if there is a fracture, if there is a ligament injury, fine, it will heal because the other structures are intact. But if there is a fracture at two places or a ligament injury as well, that makes the injury unstable. So we have taken the X-rays, CT if required we do, then we have to understand the pattern of fractures, ankle fracture. What is the pattern of the fracture? And we classify these injuries. So the most common classification, the most important classification is the Lodge-Hansen's classifications, which I will be telling you in detail. Weber and OTA are very small. Once we know about the Lodge and Hansen's classification, we can easily tell which Weber type it is or which OTA classification, which is called Orthopedic Trauma Association Surgeons Classification, which is a numeric classification based on AO classification. So coming to the Lodge-Hansen's classification, so this has got 4 primary pattern of the injuries. So these are described as supination adduction. Please no talking from that side. So there are 4 patterns of injuries: supination adduction, supination external rotation, pronation abduction, and pronation external rotations. So what does these 4 pattern of injury suggest? The first letter or the first word is the position of the ankle or the foot in which position the injury is subjected to, and the second word designates the force. So in supination adduction, the foot is a little dorsiflexed, inverted, and then an adduction force is applied to it. And as we understand how the adduction force is applied, we'll understand how the what the fracture pattern it leads to. Then there is supination external rotation, pronation abduction, and pronation extension. So from SAD to PER, the injury pattern has evolved, and it is supination adduction is the most simple pattern, and as the severity grows, this goes into from SAD to SER, then PAB and PER. Another important thing is, this again I will repeat later, the fibular fracture. The level of the fibular fracture goes higher and higher as the severity pattern increases. So let us come to the, so there are, secondly I want to tell you, there are 4 basic patterns of the injury, but in each injury pattern there are stages. Like in supination external rotation injury, which is the most common injury, the injury, the force of trauma can stop at stage 1 or stage 2 or maybe stage 4. And depending upon the stage at which the force stops, you will get the fracture patterns. So what is supination external injury? The most common injury of the ankle. So on all supination pattern injuries, the lateral side is tight and that fails first. While in pronation injuries, pronation external rotation and pronation abduction injury, the medial structure would fail first. So as it is supination external rotation injury, this is fibula, this is tibia, that is the talus. Looking from the foot end side, the force goes like this, just that this arrow shows. So what happens? First of all, the lateral structure will fail first, and lastly the medial structure. So stage 1 would be where the lateral structures would fail, stage 4 would be where the lateral structures, posterior structure, and ultimately the medial structure would fail. So in this injury, first of all, this AITFL, anterior inferior tibiofibular ligament, will fail in supination external rotation, and this will lead to a fibular fracture. The direction of fibular fracture is also very important. In this pattern of injury, you will get a fracture, oblique fracture of the distal fibula, which will extend from posterior superior side to the anterior inferior side. If the pattern of injury continues, the posterior structure will fail now. So it is the posterior malleolus which will fail. And lastly, if it goes on to the medial side, your medial structure would also fail here. So stage 1, AITFL disruption, 2 would be a spiral fracture of the fibula, 3 PITFL or the posterior malleolus will fracture, and lastly the deltoid ligament injury or the medial malleolus injury. Understood? I hope it is clear, because this is the basic mechanism of the injury, the most common injury. There are stages. We'll come to know how to diagnose which stage it is there. So this is a stage 2 stable fracture. Supination external rotation. So this is the X-ray of the same, AP and lateral. So in AP also there is a fracture which we are not able to appreciate so clearly, but in the later view we do see that there is a fracture of the distal fibula extending from posterior superior to anterior inferior side. So by looking at the pattern of the fracture, we understand that this is supination adduction injury type 2. But it could also be type 3, where there could be a posterior malleolus fracture or PITFL injury. If there is ligament injury, we cannot appreciate it on the X-ray. And if it goes on to stage 4, there may be a fracture of the medial malleolus or deltoid ligament. If there is deltoid ligament injury, we cannot see on the X-ray. So X-ray would look like this. It would be difficult to say whether it is a stage 2 injury or stage 4 injury. So there is lateral injury, classic, posterior superior, anterior inferior fibular fracture. Medial injury, in this case, even if we take the stress X-rays, if the distance, medial joint distance is maintained less than 4 mm, then there is no injury. But if there is more than 4 mm distance, then probably it would be stage 4. Here in the X-ray it is not showing any increase, so it is stage 2 injury. Standard closed management. Closed management, that means plaster management we have ensured by excluding stage 4. If it is stage 4, which the X-ray may appear like this only, and you give plaster treatment, then it would be a failure. So this is stage 4 injury. Here in this case there is a clear distal fibula fracture pattern, which is the same, posterior superior to anterior inferior, plus there is a medial malleolus fracture. But here we do not see a medial malleolus fracture. This could be stage 2 injury also. But if you see the medial joint space, this is more than 4 mm. So this is stage 4. Lateral injury we can see. Medial injury, medial malleolar fracture or deltoid ligament injury. So this would require a surgical management, that is anatomical restoration of the fractures. So how do we decide whether it is supination external rotation stage 2 or 4? By looking at the medial side, which may appear normal on the X-rays. So goal is to evaluate deep deltoid ligament. If there is fracture, it is obvious. If there is no fracture, then we have to evaluate. So what are the methods? Clinically, you try to see medial tenderness. You know where the deltoid ligament is on the medial side between the medial malleus and a little distally. Try to palpate. If it is not tender, then there is no injury. Swelling. If there is deltoid ligament injury, there will be swelling over the near the medial malleus. If there is no swelling, probably it is stage 2 only. Ecchymosis. If there is deltoid ligament injury, there you may see ecchymosis. If it is not there, there may not be stage 4. And lastly, you have to take stress views. As I told you, by the gravity method or by everting the calcaneum event talus, you can rule out the stage 4. Stage 2 versus stage 4, how to decide? Here, if you do a stress view, you would find that this joint space is increased. Stage 4, unstable, needs anatomical restoration of the bone fragments, fixation of the lateral malleus fracture. So this was about the supination external rotation injury. The next that we are going to learn about is supination adduction. So instead of supination and external rotating, the foot goes into adduction. The lateral structures are stretched, the medial structures are compressed. So that is the direction of the force from lateral to medial side. So which structure would fail first? The lateral ligament, or there may be a pull-off fracture of the fibula. So the injury pattern can stop here itself, just a tip of the fibula fracture, or if the adduction force continues, it will hit at the medial malleus, and this is the kind of fracture that you will get. So that is supination adduction injury. The fracture pattern would be a vertical medial malleus fracture. So there is lateral injury, transverse fibular fracture at or below the level of the mortise, and here you see the fracture of the medial malleus, which is vertical shear type. Then we come to the pronation external rotation. So instead of being in supination, the foot is now pronated, and now it goes into external fixation. So the difference between supination and pronation external rotation injuries, then that in supination, the lateral structures would fail first. That is AITFL, lateral malleus. Here, the medial structures are going to fail first. So this is the ankle, medial malleus, that is the fibula. So stage 1 would be a deltoid disruption or transverse fracture of the medial malleus. Next, there will be AITFL disruption, anterior inferior tibiofibular ligament. This can fail. And stage 3 would means a spiral fracture of the fibula. This spiral fracture of the fibula will be higher up. While in supination external rotation injury, we saw that it was a lower one. In supination adduction fracture also, it was a tip of the lateral malleus lateral fracture. Here the level of the fibular fracture goes up. It is somewhere high up, and this is, we'll describe it Weber C fracture. And in the stage 4, there will be lastly PITFL or a posterior malleolar fracture. So here, that is a posterior malleolar fracture on the posterior side. Okay. So this is what happens in stage 1, medial malleolar fracture or deltoid ligament rupture. Stage 2, AITFL rupture. Stage 3, a fibular fracture, which is higher up. Stage 4, there may be a posterior malleolar fracture or PITFL injury. Medial injury, deltoid ligament or transverse medial malleolar fracture. Next is lateral injury, spiral proximal lateral malleolar fracture. Then syndesmotic injury is common. And then we come to this pronation external rotation injury. The whole leg has to be x-rayed because your fibular fracture is higher up. So the syndesmosis is also disrupted. Sometimes the fibular fracture is as high as near the neck of the fibula. So that is why it is important when you get an ankle injury case, you must palpate the whole length of the fibula, because the injury is at the ankle level, but the fibula fracture may be higher up because of the indirect transmission of the injury. And this particular fracture is called Maisonneuve's fracture. There are certain more eponyms in the ankle fractures, which I'll tell you later on. So this particular fracture is called Maisonneuve injury. Then there is pronation abduction injury. So here in pronation, the foot is, the initial position of the foot is pronation, and then the force that is applied on the foot is a abduction force. So what will happen if there is abduction force? The medial structures will fail first, like this. This is a type of a pull-off fracture of the medial malleolus, and then this lateral malleolus will fracture. But with the eversion, there will be comminution of the fibula on the lateral side. That is the particular type of pattern that you get in pronation abduction fractures. So medial injury is transverse to short oblique medial malleolar fracture. Then there is lateral injury, comminuted impaction, because the talus is taking the foot into abduction and fibular cortex gets compressed. You get comminuted fracture pattern. So that was Lodge-Hansen's classification, but you can also translate it into Weber classification. Easy to understand. Depending upon the fibular fracture level, it is classified into A, B, C. A is below the ankle, below the syndesmotic level. B is at the syndesmotic level or the ankle joint level, and third is above it. So as we learned from supination adduction to pronation abduction injury, the level of the fibular fracture goes higher and higher as the severity goes on. So Weber type 1 is supination adduction injury. Weber type B is supination external rotation injury, where the fibula is at the level of the mortise, at the level of the ligament. And in C, that is the last, the fibula is higher up. So concept is, the higher the fibula fracture, the more severe is the injury in terms of syndesmosis disruption. So this is supination adduction injury. The fibular fracture was lower down. This is supination external rotation. As the severity increases, your fibular fracture level goes up, Weber type 2. And this is pronation external rotation, where the fibular fracture goes up. So we learned about Lodge-Hansen's classification, the Weber classification. The third is OTA classification. So this is also very alphanumeric classification. AO classification we must have already studied about the bones there. They are numbered, like humerus is 1, forearm is 2, femur is 3, and tibia is 4. Then again in the tibia there are 4 parts. So this part becomes 4 and this is 44. So we do a classification based on ABC. A means below the level of the joint, B is at this level, and C is above this level, just like Weber type. So we will not go into the details. Then there are certain common names of fracture pattern variants, just as I told you, Maisonneuve's fractures. This is a pronation external rotation injury, where the fibular fracture is higher up, near the knee joint, just below the knee, at the level of the fibular neck. Then there is Volkmann's fracture. What is that? This is a fracture of the posterior malleolus, or the PITFL, posterior inferior tibiofibular ligament attachment avulsion fracture. Then there is Tellox-Chaput fracture. This is AITFL, anterior inferior tibiofibular ligament avulsion fracture from the tibial side. AITFL is attached from distal fibula to the distal tibia. So the avulsion fracture of that. This is Tellox-Chaput fracture, avulsion fracture of the AITFL, and we have restored the anatomy by putting in a CC screw. So what is Dupuytren's fracture? This is basically a fracture of the both malleoli along with dislocation of the ankle joint, tibio-talar joint. Now, as I told you, the fracture type of pattern of fracture also depends on the age of the patient. In children, we have a growing epiphysis. So, this classification of ankle injury is basically a general classification, whereas in type 1, we have got an epiphyseal injury. In type 2, there is a fragment of the metaphysis. This is the fracture pattern. Type 1 is this, type 2 is this. Type 3, if the epiphysis is fractured, that is type 3 pattern. Type 4, where both epiphysis and metaphysis is fractured. And type 5, where there is crushing of the epiphysis. The importance of analyzing this is that you can predict that there may be some growth anomaly later on. Even if the fracture heals anatomically presently, but later on the epiphyseal growth may be disturbed and patient may have angular or rotational deformities or the length discrepancy, the limb may become short. So how do we treat this injury? We will not go into the details, some basic concepts only. So in an emergency room, what you do is, if it is a grossly displaced fracture, you can easily manipulate it with your own hands and do a closed reduction. So just if there is dislocation, that is an emergency, reduce the dislocation. Dislocation is of the tibio-talar joint. If the if the talus is grossly displaced out of the ankle mortise, you can easily restore it. By restoring a dislocated bone, by reducing grossly displaced fractures, please pay attention. So you reduce the swelling and you apply a well-padded posterior slab and limb is elevated till the swelling is reduced. So where do we give a non-operative treatment and where we have to give a surgical treatment? So non-operative treatment indications are undisplaced fractures, stable fractures. If you've got you understand that ring concept. If there is two fractures in the ring, two places there is disruption, it is an unstable fracture. Even if it is non-displaced, it is an undisplaced. So in these fractures, we may require surgery, but stable fractures, non-displaced, we can do with plaster of Paris. Patient not fit for surgery obviously is an indication for non-op treatment. So how do we do it? We apply a well-padded posterior plaster splint. Well-padded because these injuries are often associated with a lot of swelling, or the swelling may develop later on. If you apply a snug plaster, there may be some compromise on the vascular status of the foot. So it's good to apply a well-padded cast. This cast is applied for 4 to 6 weeks, and then we get a check X-rays done. When there is a good healing, then we can make the ankle move. We remove it from the plaster. And weight bearing is restricted until fracture healing is adequate. Usually this takes from 6 to 12 weeks, maybe 3 months up to. So before 3 months, we may not advise the patient to weight bear. So operative treatment obviously is now reserved for all unstable fractures, all open fractures. What is an open fracture? A fracture in which there is a wound associated with it, where the fracture has been exposed to the exterior side. So there is potential danger of infection, the bone getting infected. We must do a surgical debridement, and in such cases we make use of this opportunity and internally fix the fractures. So surgery is only done when this swelling becomes less. So we may have to wait for some days, and during this waiting period the patient may be in a well-padded plaster for 7 to 10 days, or maybe in skeletal traction, or maybe we apply some external fixation for the swellings to reduce, and then a definitive fixation is done. So various methods, we are not at all going into the details, but we should understand the concept of internal fixation. So what do we do in medial malleolar fracture? We use a cannulated consul screw for fixation. Another common method of fixation is a tension band wiring, where we use two K wires and a SS wire to put tension across the fracture site. For fibular fractures, we may use a leg screw, or if it is a long spiral fracture, we may use a neutralization plate with screws. This is how we do a tension band wiring of the medial malleolus. We put two K wires in and pass a wire to apply tension to it. This is a fibular plate. This is a leg screw which is legging the. I'm sure this concept has already been taught to you when how to do internal fixation of the bones. What is a leg screw? What is a compression screw? What is a DCP and all. So this is a leg screw with a plating. See, this is a medial malleolar fracture. This is how we do a tension band wiring, or we can make use of two CC screws, cantilever cancel screws. So that was all about this. Thank you.